So, this is benzodiazepines, uses, risks, and how benzodiazepines really do overlap, and the risk associated with being on a benzo and Suboxone or buprenorphine products and or opioids. We have to owe some of our slide content to Charlie Resnikoff. These slides weren't really created by him anymore. We totally changed them, but we stole them. So we do.
He's stolen some of ours too. So
I know, but it's good. But I'm just saying, I'm giving him credit, man. It's Charlie Resnikoff. These are recorded. Y'all just got that pop up. Obviously, the free CME. There'll be a things emailed to you and a link probably in the chat at the end. Attendance, again, most people are really good at naming themselves now, but if there's other people in your room with you, please just put that in the chat. We just want to make sure that everybody gets the credit. And please turn on your video. We got, 3 friends that turned their video on. No, I don't care if you're eating. Case presentations, if you have a case and you want to use a fancy form, or you have a case and you want to just talk through it, even at the end, if you're just like, oh, this talk made me think of a patient I once had or have, even if you're not currently seeing patients, Nancy Baker, you've probably had some experience dealing with this patient population, just to talk through things. It really helps everybody to hear things like that, not to call you out or anything. She used to make me do case presentations to her in med school, so this is payback. Upcoming 2 weeks from now, opioid use disorder with alcohol, and then you can do stimulants, pregnancy, babies. Oh, there's a really cool talk I'm going to tomorrow on neonatal abstinence syndrome. And so hopefully we'll have some more stuff to add to that. We are not having an echo tomorrow. We are actually speaking, literally overlapping it, I think, at the National Drug Summit, which is why we're in separate rooms in Atlanta right now. And so I have to say what just happened to you, Kurt. I'm taking time, I know. Kurt was just at one talk. I was at a different talk, and he got up and asked the question because of somebody from a rural community and did something in somewhere in the middle of Nowhereville, New York, and asked the question. And the presenter, after Kurt got done, said, "You guys know who that was? That's Dr. Kurt DeVine." And him and Dr. DeVine and Dr. Bell, it was like, oh my gosh, that's crazy. And then talked about our podcast too, which is really super cool. But anyway, you can see what's coming up. I think next week with this whole reform, we still get questions about the Rule 25, the chemical use assessments, what's happening with that. We've been talking about the changes for years now. Test strips, Charlie, you can read. The podcast, yesterday we released today released episode 100. So that was pretty fun. And so, yeah, that's how you get on there. And email us if you have other thoughts or questions. And technical assistant, same thing. If there's any questions or patients you want to run by or you just don't quite know, something comes up, it doesn't have to be a patient with opioid use disorder. It can be someone, maybe you're thinking about it, or any other kind of, medications, whether it's opioids, benzos, yada, yada, alcohol. Let us know. That's how you get a hold of us. Erin as well is our nurse, so she's available to help as well. Okay, objectives. Kurt, I think you're gonna start, or do you want me to start?
I'll start. That's fine. Okay. Then I'll just turn it over after a bit when I tire out. So this is kind of busted up into sections. The second section is a little bit more about benzodiazepine use when patients are on buprenorphine, which is a common question we get asked. So we're going to talk about that. Next slide. So this is kind of the overview. And again, we're going to talk about examples of them, indications, some of the pharmacology, a little bit about withdrawal and tapers and some of the side effects that we'll see with this. Go ahead. If I pause, Heather, just go for it. So remember, these are considered sedative hypnotics. But sedative hypnotics really covers a fairly large group of drugs and substances. And it would include, of course, alcohol, the Z drugs, anything that's a sleeping aid, barbiturates, GHB, which is a date rape drug, propofol, some of the inhalants. And even if you look at sedatives and hypnotics, gabapentin and pregabalin, Lyrica sometimes can be considered in that same group. So keep that in mind, that they're very well as kind of that question whether or not they fit into this group. So the list of these is amazingly long, okay? And these are just the ones that we prescribe. And I can tell you that even just last week, somebody came to me with with something that somebody was taking etozolam or something that they were buying on the internet. And so the list of the ones that are bought off the internet that are more designer type drugs is extremely long. So it can be very confusing when we get drug screens, because remember, not all of these will show up in a urine, and we'll talk about that in a little bit. But these would be examples of some of the benzodiazepines commonly used. So remember, sedatives are GABA stimulating drugs, okay? They have some incomplete cross tolerance with a lot of other different drugs. And if we look at where barbiturates kind of tend to affect the midbrain and where general anesthetics come in, the benzodiazepine site is a little bit different. And so it has a slightly different effect, although a similar effect. And remember, that sometimes there'll be cross tolerance if people are in withdrawal. And that's why you'll see people, for instance, in benzodiazepine withdrawal, they might use gabapentin or things like that, because there is some overlap of that. So what are the effects of the benzos? What people take them for illicitly is typically the euphoria or the bliss. And I don't think there's any of us that haven't had some experience with people who had taken too many benzos, and they take them more and more and more and enjoy that kind of euphoria that they get with it. We use these medically for obviously seizures, and very commonly Valium and things like that, and Librium to avoid seizures in people with alcohol withdrawal. But one of the interesting parts about benzodiazepines is that at significant doses, a lot of times we get amnesia. I almost said anesthesia, amnesia. And that can be a bit of a problem, because sometimes when people take these medications, even if they're prescribed, they won't remember what happened that day, or they'll forget certain aspects of their day. And it definitely causes muscle relaxation. We'll talk a little bit about some of the clumsiness. And some of them, typically in my era, if you will, a lot of physicians were giving those that, don't smile, Heather, when I say my era. In my era, a lot of times people would give those to people in the evening to kind of help them relax so that they go to sleep. But they're typically should not be used for sleep. I think we should kind of avoid that. They do cause some respiratory depression. We're going to talk about that, especially towards the end of the talk when we talk a little bit about Suboxone and some of the benzos. So that's something to kind of keep in mind. And again, most of it is about taking away anxiety. And do they help anxiety? I don't think there's much question they do. But remember, even opioids decrease anxiety, and that doesn't make it the perfect drug. Clearly, opioids are not a drug that we want people to be using for anxiety, but it's not uncommon. So do you get tolerance to benzos? Well, you get tolerance to benzos effects. So over weeks, the euphoria and those feelings will slowly decrease. And in fact, the ability to suppress seizures can sometimes be diminished over time. And some of the effects are incompletely diminished, especially amnesia or the relaxation or the clumsiness. People do, just like with alcohol, people can build up that tolerance where, in fact, they can be driving at 0.3 or 0.4, and they have enough tolerance that they actually can perform pretty well. But they can be sleep-inducing, although they may not keep people asleep for any significant period of time. So some of the effects that the durable effects, the things that hang on, is really respiratory depression. So that's the problem. If you can't get euphoria unless you take a higher dose, you're really playing around with the problem, the biggest problem, which is the respiratory depression. And so that may still be there and can get worse when you take those bigger doses. So let's talk a little bit about the pharmacology, because I think it's important for people to understand these things are all different. The potency is all different, and there's you can get graphs that'll kind of give you an idea of how potencies kind of go across the board. And for instance, if you look at a milligram of diazepam, it's much less potent than a milligram of alprazolam. And again, one of the ways that we define these medications is really their duration of action. A lot of these have very long durations of action, and half-lives can be amazingly different. The onset of action is actually really interesting, because you do have some that actually their onset will be very quick, but yet they still last a long time, which is unusual. And Xanax would really be the example of that. And that's probably why it's the drug that's often misused. And again, one of the things that we have to always think about is some of these have active metabolites and some don't. And the active metabolite can really make a big difference on their liver safety and how easy they are to taper for people. So understand the drugs that you're prescribing and which of them have the metabolites that can be a problem. Take over anytime you want, Heather. So duration.
Related. Keep going.
Okay. So there's high variability in the half-life. So again, some of these, like midazolam, which is Versed, right? Versed, that will go away very quickly. So we use that for particular procedures because it will be gone quickly. People can wake up and go home from their colonoscopy. And then you have things like lorazepam, which may last 6, 8, 10 hours. And it's great for a panic attack and phobias because it kind of calms those things down, has a reasonable time of onset. But then you have things like diazepam, which may last even more than 24 hours. And it's something historically that we've used for alcohol detox and preventing those withdrawal seizures. But interestingly, diazepam tends to have a fairly fast onset. So, but it's got a long, long half-life. Next slide. So let's talk a little bit about those active metabolites, because the metabolites also play a role in what we can see in somebody's urine drug screen. So that's something that we'll talk about too. But if you look at some of these benzos, especially Valium and Librium, these have active compounds and metabolites. So they will, that's what really makes them last so long. And Librium is one that, when I was even a resident, we were using Librium for alcohol withdrawal, and it would last forever because it also had active metabolites. These will also need to be broken down by the liver. So it takes time for them to break down as well. So if you look at people with any kind of liver disease, these are medications you probably want to avoid because they may have to go through there a couple of times until they're metabolized. So some of the active metabolites make these drugs very long acting, and in a way also self-tapering, in a way kind of like Prozac. Prozac is just so long acting that we often don't have to taper people. And so if we have somebody who has not been on a medication that's long acting like these, as long as they haven't been on it for years, you probably can self-taper themselves. So it's just interesting to keep that in mind. Next slide.
And that really becomes important when we're talking about tapering of benzos, and you'll see that as far as tapering recommendations, we will transfer patients, especially to the diazepam, to help taper them. And with the self-tapering, there's much less risk of having, seizures coming off of benzos, which is one of the big scary things, I guess.
Yes, seizures are bad. This is one of my favorite slides in the whole world. And really, it's because when we look at urine drug screens, there are things that do not show up on urine drug screens when we check people with benzos. And this is the slide to remember because so many of these things turn into oxazepam when they are metabolized. And so the dip that we do shows oxazepam. But you can see things like diazepam and Librium, those things on the left there, they turn into nordazepam. And they actually have active metabolites that turn into temazepam and lorazepam. So it just keeps going. And of course, temazepam is also a medicine used for sleep. But oxazepam is the one that is often looked for with the urine drug screen. So just remember things that we look at the bottom, alprazolam, which is Xanax, is probably one of the most misused drugs in the market as far as on the street. That one has a metabolite that is completely different. And remember, when you do a urine drug screen, it's not going to show that. So understand a benzo screen, because of the metabolites, they're not always that great. Next slide. So let's talk about onset of action again. It can be very different from the duration or half-life. So you can have something with a long half-life that actually comes on very quickly. And again, I kind of mentioned this earlier, that diazepam, actually the onset of action is pretty quick. And it's actually faster than lorazepam that has a much shorter half-life, but it also has a longer duration. So, I mean, it's really, some of these drugs have very interesting properties that make them useful for particular things. Lorazepam, for instance, kicks in very fast if given IV, but if it's oral, it's much slower. So again, I think it's so important that we understand the drugs that we prescribe, because sometimes, at least in my world, I will use these medications typically very acute cases where death in the family or, alcohol withdrawal or things like that. So, pick the right drug. Rapid onset, of course, those are the ones we want to use for breaking a seizure and doing those things. So, all right, next slide. So the variables. So again, potency differences, time of onset, duration, and active metabolites. Those are the things to kind of be thinking about when we're thinking about a prescription or a use for a particular benzo. I know you like that graph, Heather. I don't know if you wanted to. That's like one of your favorite graphs. You don't want to talk about it.
No, I mean, that one's pretty self-explanatory. Give me an opioid. That one's more complicated.
Okay. So the commonly used benzos and why? Well, clonazepam, and to be clear, clonazepam also does not show up on a general urine drug screen DIP. That's a very common one used for general and social anxiety, right? It's got a longer action. There's not as much euphoria with it, but clearly works pretty well. Works well as a medication that's used intermittently. Lorazepam, we talked about panic attacks and stuff. It's got medium onset, shorter half-life. You don't get so much euphoria if it's not that quick Xanax kind of thing or Valium kind of thing, right? And diazepam, again, that's one that's been used historically for people with withdrawal symptoms from alcohol. But just remember, if they have cirrhosis, that's a little bit of a problem because of the metabolites. Again, we talked about Versed and then temazepam, which is actually a metabolite of things like diazepam, is used for sleep. And again, very long half-life, keeps people asleep, very little euphoria, harder to misuse. Next slide. Well, so
you want me
this
to talk, or are you good still?
Go ahead. I know you like this slide too. Go ahead.
I just like things that are complicated because I know how to explain them better.
Yeah.
So actually, a lot of benzo prescriptions actually come out of primary care versus in other specialties. It's actually, Sarah's like totally agreeing with me. Even when you look at psychiatrists who you're like, okay, that's who sees the more difficult anxiety or panic and all of that. No, it all comes out of primary care primarily. And it's a lot of back pain, anxiety, just random other things, as you can see up here on the top, insomnia, neurological things. We had a provider in our clinic at one point who, like, anybody who had low back pain, regardless of the diagnosis, would always give Valium, because it's great at muscle relaxation. But and I get that there can be risks with other muscle relaxers, but I think Valium is pretty scary to kind of use for muscle relaxation all the time as well. And so you can just kind of see that this is something, and I don't know if we're just not wanting to refer patients, or it's just I don't know what else to do. And benzos are easy because they will. It's kind of like opioids. They'll help anything, at least short term. So kind of where the rules, I have to put that in quotes because nothing in medicine is ever a black and white rule, unless it's a pregnancy test, I guess, maybe. But don't use benzos for anxiety long term. Now, if someone has like a death in their family, or there's an acute stress event, or divorce or whatever, intermittent as needed benzos to help with that, the panic or the anxiety through that event. But even when I started patients on benzos for that type of event, I go in saying, this is going to help you right away, when you need it. But this is going to be maybe a 2-month prescription. So I'll see you back in a month, see how you're doing. And I don't give 30 or 60. It's like, here's 15 for a month and we'll see how it's going. And then potentially, depending on what the actual underlying patient was like, doing that assessment, do they need an SSRI as well? Because that will take time to kick in. And so, but, you got to go in saying that this is not long-term. And that's, if you take a benzo longer than 3 months, it has been shown time and time again that actually it makes your anxiety worse. And we'll get to that. Same thing for sleep. Yes, it will help you fall asleep for sure. Klonopin is everybody seems to be their favorite sleeping med. And it is a benzo. So it's kind of like alcohol. It'll help you fall asleep, but give it a few hours and then you're wide awake. And that will also happen. Again, intermittent, short-term, not long-term use, whatever. But you don't use them for alcohol detox outside of a controlled setting. So a person's admitted, obviously, if they're on like some type of a CWA protocol or whatever, they're in the alcohol withdrawal protocol, you're going to use benzos. And everyone's kind of got their favorite. Even I in residency chose Librium over Ativan. Nobody else in my residency did, but I did because you can pre-schedule it. And, you know, detox centers will obviously use Ativan. In the jail, they use Ativan. But you don't want to necessarily send a patient home with a bunch to help themselves wean out their alcohol, because if you combine the two of them, now we're really in trouble. Not a good chronic seizure med. They need to be, if you have a person who has a seizure disorder, you need to have it available, of course, but that is not the treatment. It's the let's stop this acute seizure. That's not the long term. Not for back pain. A lot of people, not a lot, several people never use benzos in an outpatient. I'm not even that black and white. Again, there are certain situations in which, you know, you're going to use them. Otherwise, like that bottom one, rare doses, daily doses over a short period is kind of what I said. You know, people who have like this horrible fear of flying, you know, they get like 2 years if they're flying. This is why they're falling out, you know. And I think this is a lot of everything kind of in what we do in any kind of addiction or even primary care. I think is like stepping back and saying, what's actually the source of why aren't you sleeping? Why are you in pain? Why are you stressed out? What is actually, why do you have back pain? Like what's actually going on? Let's find out the actual source of the thing and treat that thing. Like rather than just say, here's a med to help you sleep. Oh my gosh, do you have sleep apnea? You know, now I'm going to give you a bunch of sleepers and then you're going to die because your body isn't waking you up because you're not breathing or whatever. So, you know, people need to learn anxiety coping. Again, if there's an acute stress event, that's a different situation. Is this supposed to be a poll? Nah, we don't have polls built in. But the most important contraindication to benzodiazepine use, so here is, in your heads, you can think of it if you want to chat it in by all means, you know, is it the opioid, co-occurring opioid use, using it with alcohol, an elderly patient or a pediatric patient? This is like a typical board question because these are all high-risk patients that you should be very careful about prescribing a benzo in, but the most high risk, the highest is the elderly, which elderly isn't the correct word. We should, you know, older adults. And that is because of falls. We'll get to that. But these are all very high risk situations. And we'll kind of explain why some of these are higher risk. Yeah, a lot of primary gives it to older. And I'm going to say, I'm going to kind of, since it's on this slide. So older adults giving a benzo to, you know, you see this a lot. And I think, especially if we're talking nursing home care, this is one of the worst things in primary care, I think, is when you're a nursing home, you're rounding in a nursing home and you get this red flag thing on the chart. Like, you have this person on a long-term antipsychotic. Do you know, They want you to get them off the antipsychotic if they're having behavioral disturbances or some dementia-related behavioral disturbances. And so then they basically want you to put them on as-needed Ativan to help with their behavioral disturbances. But then they're going to have falls and hip fractures and like there's really not a great answer in that situation, and it's very challenging. But benzos in older adults, definitely falls is a huge thing, especially when given at night, because you know you're half asleep and you get up to go to the bathroom, and some people get up a ridiculous amount of times to go to the bathroom when they're older. It's just scary. So most patients, though, it's actually very challenging to have a benzodiazepine addiction. Now, you can be dependent on them because dependency is if I stop them, I'm going to have withdrawal, or the addiction is needing more and more over the time to get it. But most people are not truly addicted. Most people aren't going to go out and try to find them and put themselves in harm's way to get benzos. And most people who are doing that now are actually ending up with fentanyl anyway. And that's how it's used a lot. Like if people want benzos, it's usually because they're coming off of other drugs. They're withdrawing from meth, opioids. They're bridging. They're doing all sorts of things. And we already kind of talked about that. These are the funniest patients, and there's no way I can do this slide justice like Charlie Resnikoff can do this slide justice. this is the patient you literally cannot get out of the room, because they don't really know how. If you ask a question, they're going to give you what happened. And then you ask them again, and they're going to give you what happened, except it's going to be different. And then you ask them again, and it's going to be different again. And they just keep going, and they're just all over the place. And they don't stop talking, like waiting for Kurt to give me a mean comment. But there's just this, Carrie laughs, she's worked with me before. They just kind of ramble. And it's almost like the truth serum. And this is an ethical dilemma, because you can probably get them to be honest with you about things they probably normally wouldn't be honest with you when they're on a benzo. But it's like, do you ask that question knowing they're a little inhibited or disinhibited, I should say? They just don't remember what they're doing. They just don't remember. So they're not like intentionally lying to you. If they're in benzos, especially high dose, especially long-term, it's like talking to a 3-year-old. They just don't remember. Okay, so then benzos and organ toxicity. So another thing to just kind of think about in your head, many organ toxicity. True or false? So it's false. There's like literally no organ toxicity. And I think this is a lot of why they in nursing homes are like, well, we'd rather give this to an older individual because it's not going to mess with the kidneys that are already bad. It might mess with the liver. You just would pick a different one. But and that's exactly what that says. It's that whole, these are safer, they're not going to have these falls, but now they have all these other issues. So not saying this is an easy black and white. These are just definitely things that have to be considered. This is probably my favorite slide in this whole slide deck, is which person of these two is under the influence of benzodiazepines right now, like as of when they took this picture. So it's the bottom one. Big pupils, like big pupils. That's a benzo. The top one, that's opioid, and it's tiny pinpoint pupils. Now, there are other things that can dilate your pupils. Anticholinergics, so someone just got a bunch of neostigmine, which who prescribes that or takes that, maybe if they're in the anesthesia world. Opioid withdrawal, that's one of the things on the opioid withdrawal scoring thing is size of pupils. Some stimulants, so meth, cocaine, they're typically not as big. Dissociative, so if they're out there using ketamine or PCP or GHB, but again, they're related, so there's some of that cross sensitivity. So if their pupils are huge and you're considering dissociatives, kind of the same ball game. And then obviously if you're in a dark room, and some people just have large pupils, and if you're questioning it, if you do the light eye pen light thing, they don't respond and get as small as you would expect. So other things you'll notice when a person is under the influence of benzos at the moment, they're more labile emotionally. Again, the rambling and tangential. And unlike me, I can always find my original point. Eventually, I will come back to it. I remember what it was. I will get back to it. They really don't have any original points. Again, they tell you everything. They're clumsy. They have slowed speech, dilated pupils. And if they have weird bruising, that's from a benzo, because they have this ataxia. They typically almost like a person who's significantly inebriated. Again, they kind of have that cross sensitivity, alcohol and benzos, like the tripping and oops, there's the door. Didn't see that there. They moved it. So they typically have bruises in more bizarre places. But of course, if this is an older individual or anybody, you're going to obviously want to first make sure that they're in a safe environment at home too, making sure this isn't signs of physical abuse or all of those things. This is, I don't know, I think it's a trick question in a way. The most important responsibility you have when you are seeing a patient who is intoxicated and mental. So you see that clumsy, rambling person in your clinic with huge pupils. As a provider, of any kind of a provider, what's the most important thing you need to think about? That, oh my gosh, with their oxygenation, I should get them hydrated. Do they have safe transit home? Maybe I need to find them a place to sleep. Or what do you really need to be aware of for this patient? And it's kind of all of them, but the safe transit home. These patients are very vulnerable. They're, again, they're overly disclosing. They're kind of clumsy and look inebriated. They're disinhibited. And so And not only that, but they may get lost driving home, and just the memory is gone. Like, where was I going again? And just kind of in that little world. So there's a lot of risk to that patient if they're allowed to leave.
I think one of the risks of that as well is that a lot of times they'll get a urine test done, and you might dip them for something and it'll be negative for benzos. So it really has to be about suspicion as well. Because if they're taking Xanax, something that simple, you may get a negative benzo. So keep that in mind. Be suspicious.
And this is what I was kind of saying, that the conversations don't go anywhere. And it's always hard, I think, especially as like a student or a resident or a person early in practice or anybody who's kind of new to the game, when you're talking about people with use disorders or anybody, you never want to like interrupt a person unless you're good at it. But it's hard when you're in an exam or a clinical situation and you're talking with any type of patient in your world. Cutting them off and getting out of the room is so hard. You don't want to be rude. You don't want to you have to. They promise you they won't care. They won't remember. They won't care. They won't even realize it happened. If there's anything you really need to leave them with, you have to write it down. Again, they're not going to remember that. You just have to leave. And either, again, safety for the patient, but don't get caught in a room. So if you're looking at overdose risks, this is, quite old data. And I don't even know if I'd want to see the current data, although I've probably seen it at this conference already. But like what happened, and, that's right around the peak of the first wave of the opioid epidemic right there, the opioid prescribing. And this was the transition over to heroin. And so the combination, I think that comes up here at the end, the combination of the benzos and the opioids is bad. And so you can see that. And if you look at any of them, and why alprazolam but Xanax or diazepam didn't switch as much, it goes right back to what Kurt said at the beginning. Xanax, alprazolam comes on fast. You get a great euphoria. Diazepam, it comes on fast, but it's kind of doesn't you don't have that same enjoyment out of it.
I don't know if my favorite statistics is on here or not, Heather, but the most common combination of overdose is still oxycodone and Xanax. And in fact, somebody who's on oxycodone and Xanax is 10 times more likely to die than somebody who's on neither. So they really have a significant risk when those two drugs are mixed, sometimes with misuse.
And so, with exactly what Kurt just said, you can see with opioid or any other CNS depressant, so that would even include gabapentin or, any of the Lyricas or even alcohol, you can see it's still not as high as the opioid combination. Again, older data, fentanyl has been a game changer. So it is really hard to overdose on and die just with a benzo on board. Yes, it causes respiratory depression. It takes a really long time. So therapeutic index is what's a normal prescribing, but what's gonna be fatal. There's a big gap, versus something like, I don't know, you could probably come up with a med you guys used to use back in the day. I can't even think of anything right off the top of my head, but where there's a really fine line between where the normal dosing is and let's say, give me a name of a med, Kurt.
Oh gosh.
I'm gonna put you. My brain is not functioning at the moment. Regardless, even Coumadin, a little dose can tip you over and it could be fatal. Lithium is what I was thinking. The therapeutic index of lithium is very narrow. And so a little dose off, it can be bad. So anyway, the big risk of benzos is the accidents, is the trauma, it's the falls, things we talked about, the co-ingestions with alcohol and opioids, the other things that cause respiratory depression. Very rarely are you going to need to intubate, but you might. If there's opioids on board, obviously Narcan. You can give flumazenil to help with a benzo overdose. The problem, and you always have to remember this, is if there's even a chance there's any opioids on board, you cannot give the flumazenil because you just took away the benzo, and it actually might make the opioid overdose worse. So it's really important that flumazenil can be used, but only in the event that you know it's only benzos on board. So other non-benzo sedatives, things that are related, things that, you know, we talked about with the cross sensitivity. Soma really should never be used. Soma, Oxy, and Xanax is what they call the holy trinity. If a drug ever has like a fancy street name, it's probably not a good thing. Butalbital, Fiorinol, Fioricet. I never learned these ever, but I have had partners who were trained even before Kurt who used Fioricet all the time. And so these are also things that the barbiturates, I don't think I've ever prescribed one, except maybe in a person with seizures and patients. Propofol. So, I mean, unless you're Prince's doctor, you're not using that probably. GHB, the Z drugs, so Ambien, Lunesta, those things, and then alcohol. So other things that can cause similar. So when combined with the benzo, it's even going to be more risky. And same exact issues with the Z drugs. So these are your Ambiens. The same fall, the car accident, amnesia, you don't remember what you did. So I've already talked about this, like especially now, the Xanax bars is kind of what they refer to them on the street. It's usually just fentanyl now. And you can buy them. Kurt talked about this at the beginning. There's lots of things you can buy online. We had a patient once come in saying, I'm taking all of the Xanax, I think it was Xanax, and he'd been getting it all online from like China, and it was like exorbitant doses. And it's like, do you put them on a benzo taper, which you should potentially because that could cause seizures, but do you really know what he's actually taking? Do you really know how much? Like, how do you do a taper for something that isn't even like known because the FDA didn't have any involvement? So it can be very, very scary. And, you know, of course, the benzo screen might not even be positive. So now what do you do? When you stop benzos, there's three different kind of things that can happen: recurrence, rebound, and withdrawal. So withdrawal, the true benzo withdrawal is life-threatening. These are your seizures. This is where you need to have, you know, monitoring. Most people aren't going to say, okay, we're stopping your benzos, let's see what happens. But in like this patient we were just talking about, had they not disappeared off the face of the planet, you know, it was like, do we have them get admitted to like a higher tertiary hospital where they can at least monitor this in case, because we don't know what he's taking. Yeah, seizures, delirium, psychosis, and it can happen for a while. And a lot of this has to do with longevity of the medication in your system. Does it have active metabolites? And just all sorts of other things. Likelihood, if they've had withdrawal, even to alcohol withdrawal seizures. Yes, good question. Does TBI typically play into the benzo effect? Yes, it's kind of like almost its own comorbid condition. You know, TBI kind of just makes you susceptible and more sensitive to lots of things because there's been damage there. And even if it's more, even psychological damage makes you very susceptible to things. So yeah, benzos with TBIs, which is, if we're going to talk like PTSD wars, people who've had TBI/PTSD, it's very scary to give, oh, I'll give you this Klonopin to help you sleep because of your PTSD, but yet you had this traumatic brain injury. It's a bad setup. And again, likelihood of true withdrawal, the alcohol use, alcohol seizures, other medical illnesses, high doses. So then the recurrence bucket is especially for anxiety or sleep. You stop the benzo, the thing you gave it to them for, it comes back. So it's like, again, back to that whole thing is they never really learned the coping mechanisms or never had their actual anxiety treated. It was almost like Band-Aided all this time. It didn't actually go away. It just was covered up. And so insomnia, anxiety all comes back. And this is why people are like, nope. And then the other issue, not only does anxiety come back or sleep issues come back, but they actually get rebound. So the anxiety that comes back is actually worse than what they actually took it for in the first place. And so obviously patients hate this. It is so much harder to taper a benzo patient than it is an opioid patient, actually, you have to go so much slower. They get recurrence, they get rebounds. They don't want you to take away their meds. But you have to kind of reassure them, and it's hard. So, what do you do? If they have no history, you can slowly decrease by 10% increments. It's very slow, very slow. You need to give a lot of reassurance. You need to consider other medications or other treatments for sleep or treatments for their anxiety. Again, the long-acting ones, which will help more self-taper. They don't love it. Okay, so the summary of that part, then I'm going to let Kurt take over. Very characteristic, helpful for the acute needed panicky things, or obviously acute seizures. Kind of understand all that, understand, what intoxication on benzos look like, and then obviously understand what happens when you stop them.
All right. So this is an interesting little thing that I kind of added onto this because we get so many questions about buprenorphine and the benzos. And I think often people are really afraid to even give them short term for somebody or to start somebody on buprenorphine that's on a benzo. So we thought we'd just add this, and it's actually a number of different studies that have been done surrounding that. Next slide. So this is one that was done in 2013. It was about benzo use during bup treatment for opioid dependence. And really, they were looking at the clinical safety. This is old. This is 10 years old, but they were looking at this quite a while ago. Next slide. And so what they did is they were looking for particular clinical outcomes. They wanted to know when people were on benzos, when they were on buprenorphine, what was their 12-month retention? Was it better? Was it worse? Did they have more use of other substances? So urine toxicology results. Did they end up in the emergency department for OD or injuries? Remember, we talked a little bit about benzodiazepines and falls. And so they were kind of looking for what happens to patients if we do have them on both. Next slide. So what they found was kind of interesting is that the 12-month retention was actually only 40% of the patients that they had on buprenorphine. And I think that most of the treatment places like ourselves, we hope that we hit about 60% of patients that stick with us at a year, roughly. But benzodiazepine misuse nor benzodiazepine prescription use was related to retention or illicit opioid use. So basically they found that people that got benzos during the time they're on buprenorphine didn't really dabble with other stuff or cause more issues. But the biggest thing was they were associated with the 73-time higher risk of accidental injury. And it was 4 times higher than this in females. So really that whole risk of falls and that whole risk of injuries, driving, accidents in people that are on both is pretty significant. But it was when they looked at the types of benzos that people were on, they found that it was much lower risk or slightly lower risk with long-acting benzos. So the things that are a little bit longer acting, like the Ativans, were better than things that were a little bit shorter acting. The Z drugs, or again, all the sleeping pills, the Ambiens and those types of things, actually had much lower risk of any trouble associated with the benzos. So one of the thoughts was that switching people to long-acting benzos or Z drugs is probably more safe than the short-acting or fast-acting Xanax types things if a patient actually needed them. Next slide. Then there was a study that I came across that's very new, which just came out in the last couple of years here. It was in the American Journal of Psych, and they were actually looking at the association between the benzos or Z drugs with drug poisonings and patients receiving bup maintenance, right? So they wanted to see whether or not we had more poisonings or death. Next slide. And really what they found was kind of interesting, that 30% of the patients who had opioid use disorder who were on medication for opioid use disorder are on benzos. So I find this pretty stunning because I have 50 patients. I don't have one on benzos. I think maybe Heather has one. And it's really pretty rare in our practice. But if you look at national data, 30% of patients on bup are on a benzo. So pretty hard to imagine a third of those patients were misusing them, clearly. And so again, that would be pretty normal data for opioids and benzos as far as misuse. Generally falls in that 25 to 30% block. And it was really unclear whether the risk of the benzo and medications for opioid use disorder outweighed the benefits, right? There's some risk, but did it outweigh the benefits? So there's a little bit of a question mark there. Some of the findings suggest that the retention of patients was better in a buprenorphine program if people were on benzos, whereas the other study showed that, the retention wasn't that great. But they felt that in their study, there seemed to be kind of a trend. But benzodiazepines in their study was related to a lot more poisonings. So, and so their concern really was that the interaction with benzos with different half-lives and potencies and so on is probably part of the morbidity and mortality. They didn't study that, but they had that concern. And there's little research on drug-related poisonings with Z drugs, and there still is not. Remember, this study is just a year or two old. So we don't really know, as far as the sleeping pills, what kind of risk we really have, especially related to bupe. And remember, bupe really has a fairly low issue with respiratory depression. I can't recall. Yeah, and Danielle says they have 3 of 79 that are in their buprenorphine program that are on benzos. So that's certainly not a third. So I would say that most of us are not finding that to be as high a level. Next slide.
I will say, though, that this is where we've kind of evolved. At the beginning, we put it as an allergy in patients' charts as far as like contraindication. So benzodiazepines, contraindication if they're on buprenorphine. I don't push that anymore because, again, I do have a patient on benzos right now. But it is definitely something to be aware of. Don't want to do it. And I think we did that a lot, especially at the beginning when buprenorphine Suboxone was just so not well known. And we didn't want somebody putting them on at least put that pop up. They can't be on that.
Yeah, and I think as well, I was afraid like if there was a death in the family or they had some other thing. I was kind of afraid early on to put somebody on a short-term thing. And now I think I'm a lot less concerned unless they had a clear problem with benzos in the past. So I think that it's patient by patient. You don't want to draw a big, dark black line that you won't cross. So, all right, next slide. So there is a research gap, and that was really what their conclusion was, that there really needs to be a lot more done on this, especially with the Z drugs, which there's basically no data on. So stay tuned. I think this is going to be something that's going to be worked out over time. Now, this is another study by Zhu. I don't know if you say Zhu et al., but and he analyzed non-fatal overdose poisonings associated with specific benzos or Z drugs and kind of their dosing regimens in patients with OUD. So this is patients who are on buprenorphine as well. Next slide. And basically, they found something interesting, which I don't think is surprising, right? If you take your buprenorphine, the days that you actually take the medicine, you have decreased poisoning. Because again, when we talk poisoning, it could be any other drug mixed with that. So it could be they took their opioid and they had a benzo in there. They took something else. But the days that they actually took their benzos and Z drugs doubled their poisoning risk. So clearly the risk is with the benzo and not the buprenorphine. When you take the buprenorphine, you're typically in good shape. So, but I think one of the most amazing things that they came up with, that if you looked at benzos and Z drugs plus buprenorphine, so you've got a patient with opioid use disorder on bupe, and they're also taking a benzo, they have less risk of death and poisoning than a person just on a benzo or a Z drug alone. Now, I don't think that that's something that we would think would be possible, but remember, buprenorphine has a very safe profile as far as respiratory depression. So if you have somebody on a benzo alone and they use an opioid or they use something else, those patients have much higher risk of just being on a benzo and having the risk of taking other drugs that cause their death. Buprenorphine itself does not, the dose did not matter as long as they were on it. Patients who were on SSRIs did not change the risk as well, and they looked at that in the study. So the take home on that is that if you're on a benzo and bupe, it's still better than just being on a benzo alone because you can mix an opioid in there and be dead. So that's the take home on that. But there was clear dependency for the dose, and especially with their overdose risk and the outcome. So the lower dose and decreased treatment duration, decreased risk. So when you're talking benzos, a low dose, short duration of treatment, your risk is less, but not zero. So long-term use, higher. One last study. This was actually an association between benzodiazepines and the opioid prescription mortality among patients in a large health system. Now, this actually just going to pull in the opioids just a smidge, just because I couldn't ignore it. Next slide. And really, they were just looking at opioids and benzos and co-prescription. And I think this is something that's always talked about with report cards and how we're doing as far as prescribing. This was actually taken from a large study from California with their state prescription drug monitoring program, much like ours. And they looked at 5,200 patients and about 2,000 of them had OUD. So lots of controls. They had 3,000 controls. Next slide. And really, they're in their discussion. What they decided was that OUD patients had more often other substance use disorders, and we talk about that all the time. If you have one substance use disorder, more likely to have a second. Plus, they also had mental and physical comorbidities. OUD patients were prescribed higher doses of benzos. Wouldn't have thought that. So if you look at patients who are already on had an opioid use disorder, they were frequently on more benzos and higher doses than non-OUD patients. Why? They ask for them. They feel like they need them. They have more symptoms. They have more mental health. And their average daily dose of both was associated with all-cause mortality. So whatever your average dose was very much related to your death rate. So it's really that significant interaction in the co-prescribed patients that causes the mortality in these non-OUD patients. So keep that in mind. I mean, again, we harp on this a lot about the opioids and overdose death, but clearly the higher the doses, the higher the risk. Next slide. And if you look at opioid use disorder patients versus again, opioid use disorder patients have higher all-cause mortality across the board. Higher doses of benzos are prescribed to these patients on average. More physical and mental concerns. This is kind of the review here. And previous research has also shown that more benzodiazepine prescriptions in chronic pain patients, and especially they get them at higher doses. So why that happens, I don't know. I think my personal opinion is it's the prescriber that just is much more doing that, because I don't think I've ever done that. And I think that people that tend to prescribe more opioids probably tend to prescribe more benzos. Next slide. So, and again, opioid and benzo prescription and mortality, use of either is related to increased all-cause mortality. All-cause mortality is dose-dependent. 36% of OUD patient deaths had benzo. Remember that, that's over a third. 35% of non-OUD patient deaths had benzos. So again, benzos are there a third of the time. And again, benzo dosing. The higher the dose, the higher the all-cause mortality across the board. Next slide. Interestingly, in their study, other factors associated with mortality are self-pay, older age, which again, we talked about, alcohol, which is no surprise, and frequently having many other medical diagnoses. So these are things that I thought were really interesting, and I think that we have to always consider when we prescribe anything. So next slide. So summary, patients in treatment for OUD have significant increased risk of injury. Remember that. If they're also prescribed benzos, that's important. Z drugs are associated with fewer injuries. We need to keep that in mind. We don't get benzos for sleep. That's a fall waiting to happen and a hip fracture. Patients on bup have 2 times the risk of overdose if they're on benzos, and patients with OUD on benzos have an increased all-cause mortality that's dose dependent. And I think that's probably that one thing that I want everybody to remember is you got those 2 things, your all-cause mortality is sky high. So I think that's it, Heather. Next slide. So lots of sources, feel free to pull those up, and there's some great papers about all of those things. And I think that for me, I've kind of changed my thinking on buprenorphine and occasional benzo. It's not like can't ever do that. It's like be really, really careful and make it short term. So any questions at all? That was fast and furious.
That's fast.
I had to. I was running out of time. So, all right. Any questions at all?
I do want to just make a comment about a patient, and it's not a patient I saw, it's a patient my husband actually saw. This is a guy that was kind of just acting a little bizarre. This guy was prescribed prior to Christopher meeting him intermittent Klonopin, like literally he had 5 prescribed to him over the last couple months. So nothing like high risk, but he was just acting bizarre. couldn't leave a urine, and then was doing some really bizarre things in the bathroom. In our one clinic, we can't do point of care urine testing. Well, the nurse had commented, like, this is like the cloudiest urine we've ever seen, like super cloudy. So he had it on like a urine, like actual UA, and it came back like with nothing in the urine. And, you know, again, he's on Klonopin, so that was expected. And he didn't do the thing you have to remember to do and ask, when did you take your last one? Because again, he's on 15 over 2 months. Like, he might have taken his last one 3 weeks ago. It would be negative. But anyway, he got the confirmatory test and everything was negative. Like all the individual breakdowns, Klonopin, Xanax, Ativan, all of those, but you know, the generic names, except there was something that said could not answer the question of oxazepam being there, because there was some type of a contaminant impacting the oxazepam result. But it's interesting because all the other drugs that break down into oxazepam were all negative, but it couldn't find oxazepam because of an adulterant, which just very interesting, like weird drug screen.
Yeah. And again, Klonopin would not metabolize into oxazepam.
Right.
So it's funny that one wouldn't work. So, all right. Any other questions? All right. We're just about to time. Is anybody using clinical decision support to alert the red flags you mentioned? I can't read the rest of that.
You know, this is more of a in clinical practice thing. You know, you can't signal somebody out like, oh, you're a cash pay patient, you're high risk, now we can treat you this way. You have no insurance, so now we can treat you this way. I mean, you can't do that. Like in Little Falls, we had a convent next door, and literally the nuns had urine drug screens in the same care plan contracts that everybody else did. You can't set them out, but I mean, you can anecdotally be aware of that. You know, it's kind of like when we were in practice in Little Falls, and if somebody was driving 50 to 100 miles to come to our clinic, that's a little fishy. And we found that nobody who drove more than 30 miles to get to us was kind of like on the kosher path. Like they were all having weird things. They all had multiple prescribers. And it was just a lot of questionable behaviors. But clinical decision support is a really fancy, nice way of saying it, but that's more of an internal. There's no like screening tool to use. You'd get in trouble very quickly with discrimination.
All right. Well, let's let everybody go. It's 1:14 in a few seconds. So thanks everybody for coming. We're back in a couple of weeks. No echo tomorrow. So just keep that in mind.
There's a link, Nada, in your chat. It's the middle one of all the things that are in that chat that says to get the evaluation following today's session, and you have to do the evaluation and then you'll get your CEUs. Otherwise, I think there is a follow-up email you'll get as well.